The pearl I'll give any patient is that if you're concerned about something, mention it to the scheduler when you schedule the exam, not when you walk in. If you're like, I just want an eye exam, I just want to get checked out. That's actually not a covered service. You need to have a complaint, like I'm having dry eye or glare. I was told I had an eye pressure increase at like a screening. That's a legitimate medical complaint. So if you're having trouble driving at night, I'd call the ophthalmologist and say, I want a consultation with the ophthalmologist because I'm having difficulty driving at night. So that when you check in, they'll know what your chief complaint is.
Hello, and welcome to Not Born Yesterday, a podcast dedicated to older adults and the challenges and joys of aging. I'm Miriam Goodman. Not Born Yesterday examines the problems and solutions of growing older today. We bring you the wisdom and voices of experts in the field of aging and offer tips on how to feel your best, use your lifetime skills and experience, and make the coming months and years as fulfilling as possible.
I'm Lynn Winter-Gross. Not Born Yesterday is brought to you by Next Village SF, a local nonprofit providing older adults with support to help age in place.
Today on Not Born Yesterday, we are exploring a health issue that matters most as we age: vision problems and eye health. As we get older, our risk of developing vision problems increases, as you probably noticed when you first needed more light to read a menu, or the print on a price tag seemed blurry, and suddenly you're buying reading glasses. Then came the worry that driving at night or feeling that your eyes might get tired sooner started to haunt you.
So it's not surprising that vision impairment is associated with a decreased ability to perform activities of daily living and an increased risk for depression. At Not Born Yesterday, we want to keep your world in focus. And here to explain eye health is Dr. Ravi Goel, spokesperson for the American Academy of Ophthalmology and ophthalmologist at Regional Eye Associates in New Jersey.
Dr. Goel, welcome to Not Born Yesterday.
Thank you for the opportunity. I look forward to our discussion.
So at what age do people typically start noticing changes in their vision? And is it inevitable?
So, that's a great question. So when you're younger, typically we recommend that kids get screened for their vision when they're children. But as children go older, the most common cause of vision loss in the young or even in the world is something called refractive error, where somebody just needs a pair of glasses. But you alluded to the issue of aging, which is basically there are 3 or 4 big things that can cause vision loss as we get older. One is cataracts, second is glaucoma, third is macular degeneration, fourth is diabetes, and the effects of sort of chronic diseases. And often they say, well, doctor, will I get cataracts? Is that 100% guarantee? I say yes. If you live long enough, there's a 100% chance you'll develop a cataract. And then there are other diseases which are very common, such as glaucoma, which is a silent disease. And you can sort of think about glaucoma as being, hey, I have high eye pressure, which is the same as high blood pressure. I mean, an analogy to it, where you're happy-go-lucky, you're doing okay. You don't know you have high eye pressure until your side vision, your peripheral vision, starts to get worse. And then you go in for an exam. They say, oh wow, you have your optic nerve looks like it's aging. So you may have symptoms of optic nerve damage. Most commonly, the only thing we could treat right now is high eye pressure. Third thing is macular degeneration. I'm sure everyone has a friend or family member or somebody who's, hey, I gotta go get my shot once a month. I gotta go see the retina doctor, and that's been a revolution in medicine. When I finished residency in 2001, and there were no injections, and now the injections are on TV. So there's been a revolution since 2005, 2006, where my retina colleagues can inject medicine into the eye to decrease bad blood vessels, so the bad blood vessels stop leaking fluid or blood or whatever. The eyes are the windows to the body, and so that is my mission is to protect sight, and that's the passion that I have, and I think that we have a shared mission to help empower our patients to lead healthy lives.
Can we prevent any of these diseases? Or is it just we're getting older and our eyes are getting older and we're going to get something?
So you can slow things down. So if we were at the equator and where the sunlight is really intense, or in South Africa, and you're not wearing sunglasses, you're going to have cataracts that are dense and hard. Sunglasses can slow the progression. Smoking makes cataracts worse. Smoking makes macular degeneration worse. Lots of sun exposure can make your macular degeneration worse. There's something. Steroids can cause glaucoma. So there are multiple different entities that can sort of affect these different disease processes. But the most common among your listeners is macular degeneration, and I can say to my sleep, I say, look, what you should do is wear sunglasses when you go outside, don't smoke, and consider, depending on the type of macular degeneration you have, consider taking omega-3 fatty acids, wild salmon once or twice a week, green leafy vegetables. The landmark study on macular degeneration and the benefits of vitamins, something called AREDS2, which is age-related eye disease study, which use beta carotene, zinc, and vitamin C, vitamin D, beta carotene, zinc, and certain dosages will help to slow down the progression. Maybe not cure it, but slow down the progression of macular degeneration specifically.
You didn't mention that we have to eat carrots.
That's actually very interesting, because that's actually so during World War II, there was the British were developing radar, and the Germans didn't know that the British were developing radar. And what the British did was they created this whole public health campaign where our British pilots are eating this certain certain vegetables, and I think it was carrots or spinach or whatever. The Germans did not know that the British had developed radar, and the only way they could prevent the Germans from exploring further was to do this. Hey, our British pilots are eating carrots, so you have to eat your carrots. But this does go into cataract surgery, and I'll tell you this is that during World War II, and this is a great anecdote, because this is the origin of the great advancements in ophthalmology and the great advancements in cataract surgery. During World War II, there was an ophthalmologist named Sir Howard Ridley who was noticing that British airplane pilots were getting pieces of plastic in their eye, and they were not losing their eye. So he hypothesized that we could put in a lens in the eye after taking out a cataract, and that we could restore vision. But I think that so British airplane pilots, fighter pilots have contributed greatly to the advancement of ophthalmology.
One thing we always hear about is that you need more light as you get older. Why is that?
I think that has to do gradually to retina aging, cataract aging, etc. So lighting is very important in terms of how, when light comes into the eye, it bends, it refracts, it gets processed on the surface of the retina. So anything between the outside world and the retina can cause changes to how we perceive the world. And that could be dry eye, which is incredibly common. You could have scarring of the cornea. Your pupil can have some defects to it. Behind there comes the natural lens of the eye, where you get a cataract. That can cause stuff. And then between the lens and the retina, there's something called the vitreous gel, which causes floaters, which can be very floater related. But I think that good lighting often can solve problems. Patients can be frustrated because they're not seeing well, and that often is what I said earlier, where they need a baseline refraction. They need to get they need to be checked for glasses, either distance or near, and good lighting. They need good lighting, and they need to be educated on where to hold objects when they read.
You mentioned how sometimes we don't know what's wrong with our vision, or we don't notice it. Like, people don't know they're colorblind until somebody else points it out. And I know I always get tested for glaucoma when I see my ophthalmologist, but it's asymptomatic. I wouldn't know if the eye pressure was changing. So what can we do to warn ourselves that something's happening? And Lynn and I, before we started today, we said, how do we know if our vision is hurting when we're driving? How does a child in school know they're not seeing the blackboard and everyone else is? I feel like there's some way we should be able to detect that we need help with our vision.
Yeah, so the American Academy of Ophthalmology has guidelines for for when patients should be screened or or tested. Certainly by the age of 40, you should have an eye exam, and then when you're in your 60s, you should have an exam every year. I tell patients this all the time. I say, look, if there's any questions, it's easier for me just to see you because what I see is what you get. Like I'll tell you if you have a cataract, and then there's something called Miriam. You're sort of alluding to this, something called glare testing, where you can feel great driving during the day, but then at night your pupils are going to get bigger, and you may have some glare when you're driving and you don't feel safe. It's more difficult for them to drive at night. I mean, there's just aging, etc. But the pearl I'll give any patient is that if you're concerned about something, mention it to the scheduler when you schedule the exam, not when you walk in. If you're like, I just want an eye exam, I just want to get checked out. That's actually not a covered service. You need to have a complaint, like I'm having dry eye or glare. I was told I had an eye pressure increase at like a screening. That's a legitimate medical complaint. So if you're having trouble driving at night, I'd call the ophthalmologist and say, I want a consultation with the ophthalmologist because I'm having difficulty driving at night. So that when you check in, they'll know what your chief complaint is. And the technician, when they measure you, will measure you for glare, this and that. Like, hey, this patient's coming in because they have a family history. Their sibling was just told they had a glaucoma, or their sibling was just diagnosed with macular degeneration, or they fell and hit their eye. Like all these different symptoms you can have are very important for us, and they make the patient's time and the physician's time much more valuable and much more high yield.
I'm not going to tell you that I just had an eye exam and I made an appointment, said I just need my annual eye exam. I didn't tell them any other issues. And I don't know if I have other issues. It's hard to know if you have other issues. And as Miriam talked about with driving, it's like, I don't know during the day when I'm driving if I'm having eye issues or not. I just don't know.
Well, you can do a couple things. One is on your computer, you could just look up an eye chart. It's called a Snellen eye chart, which was developed in the 1860s. And you can just stand 5 or 10 feet away. You could just check yourself, with your glasses on, or just go to the ophthalmologist. There are rehabilitation driving schools for older patients. I've run into this with my patients who've had strokes, where their visual field is cut in a certain area, and they may or may not be safe to drive. And safety, don't forget, you're driving, there are kids standing in school buses, people crossing the street, etc. So I think that I know in some states patients have to get checked at a certain age by a physician in their state. If you don't feel safe, then don't drive and get checked out. Uber's cheaper than a car with an insurance anyway.
So we haven't talked about screen time and how that affects vision. We hear about it all the time with kids that they're spending too much time, but we're looking at our phones, we're looking at our computers, and we've read that it's because you don't blink enough when you're staring at the computer. But how much is too much screen time?
COVID-19 and the pandemic really highlighted this issue where the country was shut down for a few weeks, and then we opened up, and it was just me and the patient and a technician. And we started seeing a lot of these issues of dryness and headaches and this and that. So I think that there's a diagnosis that didn't exist when I was a resident, 25 years ago, but it's called computer vision syndrome. And this is where going back to basics, getting a baseline eye exam, being tested for dry eye. There's something which has worked very effectively. It's called the 20-20-20 rule. Every 20 minutes, you should look 20 feet away for 20 seconds if you're doing a lot of near work. And that will relax your combination. It will also force you to blink and let your tear film sort of, readjust. And I remember before that, I remember telling patients, look, when you're out walking in a park, in the mall or whatever, you may blink, 12, 14 times a minute. But if you're studying a contract, reading a book, doing whatever, you may blink, 3, 5, 7 times a minute. So it's a lot less. Yeah, I see this all the time where especially with my IT and technicians, high tech patients who are on their phones all day, and they're taking a Zoom meeting when they're in my waiting room, or they're taking a call. Um, we haven't been able to separate from life and work now. So.
What other advances have there been lately in eye care? I've heard about adjustable lenses, adjustable light lenses that can help your vision after surgery. What are there other new advances? You talked about some.
Yeah, no, Lynn, that's great. I'll tell you, as I mentioned, I finished residency in 2001, and for the first 5 years of practice, when a patient had a cataract, I'd say, "Miss Jones, you have a cataract. You want to see it in the distance or up close?" And that was the end of the conversation. I decided what lens the patient had. Now there are 3 or 4 families of lenses for cataract surgery. One is a lens that will reduce your astigmatism, to help so that you can see better without glasses in the distance or up close, depending on what they want. If you have astigmatism, light's coming in and processing like a football, and we want the light to come in and process like a basketball. Then there is something that you alluded to. There's multifocal lenses, accommodating lenses, extended depth of focus lenses, light adjustable lenses. But what we have found with patients, especially those, the baby boomers, is that they want to lead very active lives, and they want everything. They want the distance, they want up close, and that's where you can get like a multifocal, accommodating, extended depth of focus lens. But those new generation lenses, that could be for the patient who wants it all. I want 0 for distance, so I can see my golf ball when I hit it, whether it goes 200 yards or 20 yards or whatever. Another thing you can do is look at some free videos online. I send my patients to my practice website, to my educational resources, because you want to go in or have a family member who can help guide you on what visual demands you want. So somebody who reads books all day has different visual demands than somebody who wants to go biking all day. So or climb mountains or whatever. So that's part of the beauty of ophthalmology.
What about dry eyes? We hear a lot about that. Is that something that everybody should be taking, using eye drops as they age?
I wouldn't say everybody, but I think that, so I think the big thing with dry eye is that we're looking at quality of vision, how the patient feels. Are they feeling burny, itchy, that sort of thing? Are their eyes, bothering them? And then based on examination, we can see signs of just aging of tear film problems, or some little dots on the cornea, something called punctate. It's very common. It can be very bothersome, and it can, that smeary vision, sort of those sorts of we certainly don't want dry eye to affect your lifestyle. There are a lot of different treatments for dry eye.
Since many in our audience are older adults, are there any misconceptions about vision and aging that you want to help us clear up?
One thing you can do, which is free, and I do it myself all the time, is that I cover each eye. I look out into the world, to see how I can see. Sometimes I'll see a patient who has this terrible cataract, and they're like, "Hey, just developed overnight." I'm like, "This cataract's been there for years." And what actually happened is that the patient never covered one eye. They have a dominant eye and a non-dominant eye. They were getting a cataract or blindness or vision loss in one eye. They didn't realize it, and then they got soap in their eye, and they covered which forced them to cover one eye. Like, wait, I can't see out of my my left eye.
We've talked earlier about how vision problems affect your independence and your quality of life. So, are there tools or resources beyond the computer that you talked about that can help people with declining vision? I mean, so many people think, "Oh, I need my eyes checked for vision." They don't think about the glaucoma or the underlying diseases that might be there. They think, "Oh, I can see, so I can get my driver's license renewed." That's the main thing. So, but what else is there that anyone can do?
Yeah, Miriam. So, ophthalmology, people kid us. They say, "You guys have your one specialty, but you have 20 subspecialties. What's up with that?" There are doctors who specialize in low vision, and they have that toolbox of screens and magnifiers. The biggest risk of falling is actually in your home, right? So they have these sort of occupational type of resources. So in that case, I would reach out to your local healthcare system and see if they have occupational therapy, vision, see a low vision doctor, Google a low vision doctor in your local area, because those those specialists they have the time and they have the resources to sort of spend extra time with patients, so that they can so that they can address their activities of daily living, because that is, you alluded to this in the introduction, like decreasing vision. There are studies that show that can increase depression. I think I lucked out becoming an ophthalmologist. We're always like the poor cousins in medical school. Like, they don't understand what we do. And, we're in the outpatient clinic. We're not in the hospital where, ER and MacGyver and do whatever those guys do, so, but I think that, so I think that vision is a gift, and there are many, many resources. Certainly the advancements in ophthalmology today, I couldn't even dream about 25 years ago. Now we have these, once a month injections, or every 3 or 4 months injections, which can help macular degeneration. So, I think the future remains bright, and and other things I haven't mentioned, gene therapy, stem cell therapy, et cetera, for some rare diseases, which we wouldn't even have predicted, 25 years ago.
Well, thank you so much for shedding light on how we can age with sharper vision. Our guest was Dr. Ravi Goel.
Thank you.
Today on News You Can Use, we're talking about that hot drink we crave when we wake up in the morning, coffee. And for coffee drinkers, the scientific news is good. A recently released report from the Nurses' Health Study, which followed over 47,000 women for 3 decades, found that people who consumed coffee in midlife had a 13% higher chance of reaching age 70 in good health, free from chronic disease, cognitive decline, physical limitations, and major mental health issues.
These results add to the research suggesting that moderate coffee intake in midlife may help support longevity. But there's a precaution. Only morning drinkers seem to benefit. People who drink coffee all day long or only in the afternoon have the same mortality risk as non-coffee drinkers. So what are some of the health benefits of drinking coffee? You might be surprised to hear.
Regular coffee drinking has been linked with a decreased risk of some cancers and diabetes. It can also have a positive impact on our metabolism, boost energy, eliminate some symptoms of depression, and help us stay alert. Why is coffee actually good for us? Well, first of all, there's that alert thing. Caffeine keeps us alert. Also, nutrients in coffee, such as vitamins, minerals, and antioxidants, can protect the body and promote a longer lifespan. Coffee might subtly help your cells manage energy, repair DNA more effectively, and respond better to stress, all contributing factors toward longevity. Your daily caffeine habit may actually boost your cellular health, enhancing longevity one sip at a time.
So how much of our favorite beverage should we drink? According to Dr. Michael Roizen of the Cleveland Clinic, moderation is the key. 2 to 4 cups of black coffee a day is fine, preferably in the morning, as we've said. But don't think this is permission to go for the caramel ribbon crunch frappuccino at 520 calories or the peppermint white chocolate drink that weighs in at 620 calories.
Before you drink your next morning joe, you may want to consult your doctor to see how coffee might affect you. Coffee isn't exactly a health drink, and there are negative side effects like sleep disturbance and elevated blood pressure. It can also disrupt the effects of vitamin D, which may accelerate bone loss in older women or cause negative interactions with some medications. But if you love coffee and you hate to start your day without it, enjoy this good news.
And that's our podcast for today. Our thanks to our guest, Dr. Ravi Goel. You can learn more about Next Village SF at their website, nextvillagesf.org. Our theme music is from Hook Sounds, and Jason Dahlstedt is our engineer. And we thank you for listening. We'd love to hear what you would like us to discover and discuss. Please contact us at notbornyesterdaypodcast.org. Follow us on Facebook and Instagram, and subscribe wherever you listen to podcasts. All of these are free, and let us know our audience better. Be well, stay strong, and remember, you weren't born yesterday. I'm Lynn Winter Gross.
And I'm Miriam Goodman.